Good afternoon, everyone. Thank you for joining us. I'm Peggy McGuire, the president of the Cambia Health Foundation, and we're delighted to host this webinar today. The foundation is committed to health equity and social justice. Back in 1966, Dr. Martin Luther King Jr. said, "Of all of the forms of injustice, injustice in healthcare is the most shocking and inhumane." Unfortunately, 50 years later, the COVID pandemic has served as a tragic reminder that we have more work to do, as it has magnified the disparities that exist within our healthcare and social systems. Earlier this year, the foundation invested $1 million in the Community Health Center Response and Recovery Initiative. We did this because community health centers are playing a vital role in the recovery from this pandemic, and they're also working to foster a future healthcare system that is more just, equitable, and resilient. Today, we are really fortunate to be joined by community health center leaders from across our region who will talk about the transformative work that's being done in each of our states to build a better healthcare system for tomorrow. Before I introduce our panelists, I want to take a moment to thank Steve Lesky, Cambia Health Foundation Senior Program Officer, for his work in Healthy People, Healthy Communities, the grant area, and for his work in organizing this webinar. Steve sent out information about the work of community health centers and federally qualified health centers before this webinar, and he also sent you detailed bios for each of our speakers. So I won't go through their accomplishments as I introduce them. What I've asked each speaker to do is to introduce themselves and tell you a little bit about their organization before we get started. So I'm going to start with Rachel, please. Rachel, could you please introduce yourself and your organization?
Thank you, Peggy. Yes, I'm Rachel Gonzalez-Hanson, Senior Vice President for Western Operations for the National Association of Community Health Centers. We are the National Association for the health centers across the country, and we began back in 1971. And we represent the health centers at a lot of different levels and venues, including at legislative and policy matters.
Thank you, Rachel. Thank you for joining us today. Next, Alan.
Good afternoon, Alan Peruz, Association for Utah Community Health. We support and represent Utah's 13 federally qualified health centers, as well as the State Planned Parenthood Association of Utah, 2 additional tribal organizations, and 3 affiliate members who are in the safety net space. Our 13 health centers operate approximately 57 clinics throughout the state of Utah, serving 175,000 patients with over 500,000 patient visits. And a pleasure to be here. Thank you.
Thank you, Alan. Joan.
Hi, good afternoon all. First, thank you to Cambia Health Foundation for your continued support of community health centers. I'm Joan Watson-Patco, Executive Director of the Oregon Primary Care Association. OPCA is similar to the other organizations representing here by my colleagues, and we're the membership organization of the 33 federally qualified health centers and lookalikes in Oregon that we refer to as community health centers. And we provide training, technical assistance, advocacy, policy work on behalf of our members. And our organization's mission is to achieve health equity for all. In 2019, there were over 466,000 patients served by Oregon health centers. 90% of patients are low income, and 44% of patients identify as an ethnic or racial minority. And that's in comparison to less than 25% of folks in our state that identify as a racial or ethnic minority. So thank you.
Thank you, Joan. Next, Yvonne.
On Ketchum Ward with the Idaho Primary Care Association. We have 200,000 patients, a little over 200,000 in Idaho. We serve 1 in 9 Idahoans, so pretty broad population base. 92% of our population is below 200% of the poverty level, and about 40% is below 100%. So very low income population. Even with Medicaid expansion, we still have a significant uninsured population that we serve. And we have 75 clinics in 54 sites throughout Idaho, 14 entities. So we have a broad span here in Idaho for a broad need.
Thank you, Yvonne. Thanks for joining us today. And last, but certainly not least, Bob.
Good afternoon, everyone. Bob Marsali with the Washington Association for Community Health. Like my friends here, serving community health centers in the state of Washington, 27 of them operating over 350 sites across the state, serving 1.5 million Washingtonians, 60% of whom live at or below 100% of the federal poverty level. It's good to be with you and appreciate the support of the Cambia Health Foundation. Thank you.
Thank you for joining us. I'm going to direct my first question to Rachel. And Rachel, as you know very well, community health centers were founded in the 1960s after a series of events in US history that called for more action to address poverty, racism, and other forms of social justice. And as I said in my introductory remarks, this pandemic is just a tragic reminder of how much more work we have to do. How do you think the roots of community health centers will guide the centers moving forward to create a healthcare system that works for everyone?
Peggy, thank you so much for the question. Please let me begin, though, by thanking you, Steve, and the Cambia Health Foundation for your support of health centers over the years, and of course, for the support of the primary care associations that are joining us today. This year has been especially difficult, and these state associations have been lifelines to health centers, as has the foundation. Thank you for that. And yes, Peggy, health centers were born out of the 60s when agricultural worker families were not able to access health care. So a pilot project resulted, known as the Migrant Health Center Program. And then 5 years later, as part of the war on poverty, the Migrant Health Center model helped to lay the foundation for the Community Health Center Program. And then now, 55 years later, the health center model of care has proven to be a trusted source for quality health care that saves the system money. And one of the most valued assets of our model is the governing board that leads each health center. And this volunteer board of directors has a fiduciary responsibility to ensure accountability to funding sources and to the communities that each health center serves. And it's important to note that, in fact, that there is a statute which requires that the board of directors be comprised of at least 50% health center patients, the most valued asset for us. This ensures that health centers are going to be responsive to community needs as they establish their strategic direction and the array of services that they will be offering. This is a unique foundation that has been laid, and health centers remain focused on their respective communities. That, of course, includes looking at poverty, racism, and other social injustices that exist in their service areas. The health center model has evolved to be able to address these social determinants of health over all these years. And especially this year, they demonstrated their flexibility, being able to have innovative approaches, and the strategic partnerships that have resulted that led them to be able to foster local controlled community systems of care. The health center patients, all 30 million of them across the country, come from all walks of life and from different backgrounds. And the health center model keeps the healthcare personal, if you will, to each patient and each community. And after all, healthcare is personal. And I believe that health centers are a local solution to a national problem.
Thank you so much, Rachel. As you were talking, I thought of something I heard recently, which is don't do something about me without me. So as you're looking for solutions to these really intractable problems and situations, I think it's really brilliant that the board is made up of half of the board is made up of community members, so they can be involved in helping to define solutions. Really very interesting and forward thinking, I think. Does anyone else want to add on to Rachel's answer about the promise of the health center model or the roots of the health center model? Alan.
I think one of the things that's always drawn me to this program when I first heard about it was just that the model works, and it works in, frontier areas, in rural areas, in urban areas. And I think the model works so well because it does involve the community. I mean, it's just one of the most beautiful, healthcare delivery models I've seen in terms of equity and inclusion. And it's just something I love about what I do.
And Pam, I might add to Rachel's excellent overview that one of the things that's attractive about the community health center program in a pretty polarized political environment that we're all living through is the bicameral and support of the program from both the Democrats and the Republicans. And we've been a favorite, frankly, of the Congress for the last 50 plus years. And that is a salve to an otherwise divided nation, I think.
That gives me hope. That's hopeful.
Peggy,
Thank you for that. Yeah, Rachel.
I'm sorry to interrupt, but Peggy, if I could just add, I think the other piece that's really important is that in addition to providing healthcare to those in need, and we define that in a very broad sense, we are also economic engines, and we are changing the lives of not just our patients, but also our community members and our own staff, because we create a lot of jobs. And sometimes we create a pathway for individuals that maybe have been working at the McDonald's or what other chain stores there are, or even local stores in the community, that they end up being more engaged in healthcare and hopefully leading to a healthcare profession. So I know that we have changed the trajectory of the lives of so many, not just because of health, but because of the jobs we created and gotten help them get out of that cycle.
That's great. That's great. Thank you. Anyone else want to offer a comment here? So I have my next question ready for you, Alan. So just get ready. All right. Well, this is since you're based in Utah, I'm going to ask you about Utah, which is a rapidly growing hub for technology. And your organization has always supported innovative approaches at health centers. How do you see health centers utilizing technology, including telemedicine, to increase access while maintaining personalized care and driving equitable outcomes? There's a lot packed into that question, but that's the holy grail, isn't it?
Yeah, it is. I think one of the things that we had to recognize early on is our own perceived bias towards technology and the patient population we're serving. So for example, I think it was probably over close to 14 years ago, we started looking at text messaging, and not text messaging as a way as just appointment reminders, but text messaging as ways to promote health education. And one of the original sort of pushbacks that we received from our health centers is our patients don't have cell phones. This is early, kind of early on in that transition to cellular. And so one of the things we did quickly was we went out to health centers and did informal interviews with patients in the waiting rooms, and found out that actually that's not true. The majority of our health centers, that's their main line. Prior to smartphones, it was just the old flip phone, but that was it. And so we learned quickly that we could do that. We had to overcome expenses back in those days with a cost per text message, but it was one thing we recognized was just that bias. And 6 years ago, I think, in working with the foundation, we implemented a smartphone technology that would connect individuals with comorbid conditions and mental health diagnoses as well to their care providers and care teams through the use of a smartphone that was, simply asking them questions once a week, and it might trigger a second set of questions. And once again, that perceived bias was, our patients aren't going to like this. They're going to hate this. They're going to feel like they're being watched. And what we found in the end was actually the complete opposite of that. So always recognizing our bias and what we may think is, out of reach of our patients, and making sure that it's in reach is one of the things that we've been looking at. Another is just challenges to technology, right? Because our biases are not always incorrect until we check them, and technology is always an issue. In terms of moving forward these days with remote patient monitoring and wearable devices, and even access to their EMRs through portals. Not everybody has internet connectivity, but some can go to, the local library to do that. But we also serve, one of our largest members is the Utah Navajo Health Systems. That's in one of the most remote areas, possibly in the lower 48, with, limited to no connectivity. So we have to watch as we're looking at technology, even basic technology these days, such as telemedicine, about what are those barriers. But they do have the capability of improving access. Many of our rural locations serve a service area with a radius of 150 miles. And so for an individual who may have to travel 40, 50 miles to see their primary care provider over 2 mountain passes, having that option to visit them in what can be done through a telemedicine visit certainly does increase access to that care. So we're recognizing that it can reduce transportation barriers and maybe even for some time away. We serve a lot of patients who don't have the ability to take time away from work and can't always get that evening appointment, and telemedicine does offer a different solution that they can look at. But we're also, once again, seeing from patients, they do want to still see their providers, right? Even right now under COVID, we saw a tremendous dip in utilization at the onset of the pandemic. And we quickly rebounded in Utah, sometimes to a frightening space where it was like, we weren't sure we rebounded so quickly because people weren't taking this seriously, but we still see people who want to see their providers. So I think it's the balance between technology and the human touch. Right now, as we're moving forward, we're starting to look at population health and really driving data and looking at data to drive outcomes, right? And to look at those right now, particularly, we've just initiated a project with the Huntsman Cancer Institute in looking at COVID, believe it or not, through an NIH grant, but looking at high-risk COVID populations, using technology and different means to reach out to them with messages, with reminders, with areas that we can be supportive of, as well as using data to look at your highest risk populations and implementing interventions to get out in front of that. So we continue to look at technology, and as much of a Luddite as I am, I've recognized, the value of technology, and we're embracing it, but always keeping that lens of equity and those who have access to it, what we can do to increase that access to technology, and how we can help patients navigate this new system of health information technology.
Yeah, thank you. I think technology there's such a great opportunity, in terms of access, convenience, think about cost. It could potentially reduce cost. And then the piece I always think about is, well, there are two pieces there, and you mentioned one is, I want to avoid a digital divide where some have access to the technology that they need to live their healthiest life and some don't. But I also think about the quality of care that can be delivered. You mentioned remote patient monitoring. So I think, those are all of the things we need to be mindful of as we embrace technology as part of healthcare in the future, is how do we continue to ensure access for all and quality. But did anyone else want to comment on Alan's terrific answer there?
Yeah, I'll just comment and share a lot of the experience in, Utah has been similar in Oregon with a lot of rural communities. One patient population that has really been affected are working with our unhoused populations that we serve and continuing to provide access to those who are unhoused. In Oregon, 8% of the population served by health centers are unhoused. So our health centers have done some really creative things to use technology to continue to be able to serve this population, such as creating computer kiosks in different locations to continue to provide that access, and are using unused exam rooms in some places to just set up with computer terminals so they continue to have access, even though they may not have cellular devices or internet or home computers. They're trying to reach these folks where they are. So that's been really great to see.
Yeah, that's interesting. You have to be creative there. I also think about the access in rural communities with the broadband, challenges we have with broadband access across some of the more rural communities. I'm guessing most of you have dealt with that in one form or another.
So for Idaho, I'll just comment that the ability to do, especially behavioral health visits, telephonically only, if you didn't have the ability to do visual, was very helpful. A much higher incident of behavioral health issues, depression, isolation, and the ability to have the technology and just the permission, I guess, by payers to use the phone only was huge. And one of the things that I would just add, the hospitals and others get a lot of credit for all their technology and flashy devices. Our health centers with very thin margins were able to step up and help this community of patients. And I just found that phenomenal. And I saw some of my health centers make more progress in 4 days than they had been able to make in 4 years. And it was all because they said, I need to do this for my patients. Otherwise, they're not going to be able to get care. And that just warmed my heart.
Yeah, that's great.
And I would add very quickly, Pam, that one of the things that we saw in Washington among the health centers, and I'm sure this is true of my colleagues as well, is in less than a month's time, there was a 400% increase in the number of telehealth visits that were conducted by community health centers. So really having to pivot very quickly in order to continue to meet the needs of vulnerable populations is a remarkable thing to behold, I'll tell you.
What has been the impact on the staff, on the professional staff? Do they appreciate the technology and the telehealth visits? Do they feel like it's impacting quality, or have they embraced it?
I think it depends.
Staff?
Yeah, I think it depends largely on I hate to say it, in some cases, it's, somewhat the age and experience of the provider population or the care team. We're seeing, very different divides, and it's not always age related. But you have some who absolutely love this and embrace it. And I think what we've seen with our health centers is they're harnessing the spirit of those that want to embrace technology and really use telehealth to really meet those patient needs. So they're readjusting, work, and those that want to do, and thrive on the telemedicine side, let's get them set up to take those calls and set that up. And then the others who still want to see patients and are entrenched in that, let's let them continue to do that. And we're still seeing, like I mentioned, we've set up a telehealth platform within the same kind of thing, 4 days as 13 health centers embracing that, trying to get this thing done. We still have 2 that, their patients won't use it. And they're very small communities, and they've just said, like, our folks still want to come in and see the provider. We've offered this, but so again, it's, I think, that recognition of what the patient wants. And then, as you mentioned with providers, use the ones, like I always say, play to people's strengths. Let's find that person that really loves telehealth and does it well. And then I think what we do all as PCAs, as the National Health Center across the country is, we're open books. We share best practices and lessons learned. And it's one thing I think that's the value of having this collegial atmosphere is that we can talk about workflows and share telehealth workflows for this disease category or that, or just in general. And I think that's a great part of this community that I'm proud to be a part of.
That's great. Thank
I
you.
was gonna just
Yeah.
share as well, you know, the changes needed to care teams in order to do this well, that it's care and workflow just looks a little bit different. And, you know, as we look at quality, I mean, we've been able to pivot quickly to do this. And now that we see, okay, this is going to be an extended period, do we have the right workforce in order to do this, in order to provide that care? Health centers do not typically have, you know, enough IT tech support, you know, these kinds of things. And how do you best use the care teams you have and look at really, you know, looking at the roles and what they can best support to be part of that team for that continued quality.
Yeah, that's a great point. Really, there's so much we're probably learning through this period. You're all learning through this period and adjustments that you're making. Rachel, it looks like you wanted to add something.
I did, thank you. I just wanted to add that, you know, when we talk about the providers and how they're working through this time and the transitions that they have to go through, and I think what we should also remember is that the training programs for these clinicians are going to have to adjust. And they're also going to have to pivot to be able to provide the appropriate training, because it is different taking care of a patient telehealth wise versus face to face, not just in how to use the technology, but what questions to ask and how to approach the patient so that the patient is still forthcoming with the information that they need to be able to make the right assessment and determine the appropriate treatment. So this is going to have implications way beyond the health center world, and the training programs are going to have to get caught up really quick.
Yeah, I think that's right. And it's all about building that trust so that you can get a correct assessment and communicate clearly. And that makes a lot of sense. Joan, I'm going to turn to you now, because I think you mentioned that health equity is in your mission statement. And I know that community health centers in Oregon have always been, you know, at the forefront of promoting health equity. How do you think health systems can better realize their full potential in providing quality care and addressing disparities, particularly now in light of COVID?
Yeah, thank you, Peggy. So as we know, the COVID-19 pandemic is really shining a spotlight on the deep racial inequities and how it's disproportionately impacting people of color and the poor, and those are the populations being served at community health centers. And although the health centers in Oregon may be a bit further along in the health equity journey, more so than other providers due to their mission, they're continuously learning and evolving. And in Oregon, we also have a few tailwinds that aid in our progress. And while there are a lot of factors that will contribute to the success, I'll just share a few from our experience in addressing health disparities and leading health equity in Oregon. And these are leadership, data, payment, and care. So not rocket science, yet mission critical for our work. Without, you know, leadership, commitment, and buy-in, efforts won't be successful and sustainable. Our health center leaders are involved deeply in health equity work within their health centers and in their communities. Health equity has been an overarching theme for OPCA, our events and programming this year, and our health center executive team peer affinity groups have been focused on best practice sharing around health and racial equity and are engaged with us around health equity policy issues. We recently went through a prioritizing exercise with our health centers due to how overwhelmed they are during COVID-19 in order to reprioritize work and pivot to best meet needs. And those health center leaders told us we can't afford to pause work in this space, yet they're looking at health equity through a COVID-19 lens, such as looking at race and ethnicity data in COVID screening. And then in the data space, there's a recognition that we need data to drive decisions and demonstrate that our health centers are providing quality care and addressing disparities. Oregon's health centers have been among the first to screen for social needs, and they have been doing this for a number of years. All of our health centers are screening, and at least half are using the Prepare screening tool to do this. And through some Cambia Health Foundation funding, we actually have been convening a social data sharing collaborative, and OPCA has staff that is dedicated to support this work. Also, health centers in the state of Oregon are working with our state around Real D, which may be more unique to Oregon. Real D is an effort to increase and standardize race, ethnicity, language, and disability data. And this was passed through a bill in the Oregon legislature. So beginning in October of this past year, hospitals and federally qualified health centers have been required to report Real D data on COVID-19 encounters. Also in the data space, health centers have been reporting race and ethnicity data for years to HRSA through UDS, the Uniform Data Set, on an annual basis. And just lastly, payment and care, and these things go hand in hand to support health equity, quality care, and the reduction of disparities. Oregon's health centers have reinvented their care teams to support patients in different ways, and have payment streams, including our state APM program, that have been the backbone to this support. So our health centers really strive to provide whole person care. And OPCA has worked to help lead our health centers in care transformation. We currently have several key initiatives to support health center development in this space, namely our state APM program, which is our APCM program. So it's that alternative payment and care model program. And our APCM program has created a stable funding stream to get out of that fee-for-service model, which then supports social needs and integrated care delivery to reduce disparities. It's also been a huge benefit during COVID-19, where certain services have been hit hard, such as dental, and we need to ensure these services are sustained. So I just say that it's important for health centers to have leadership buy-in and thread health equity work throughout their organization. It can't belong to any one department or person, and ensure that they have the data infrastructure and focus to support this work, and have care teams with a model of care in place that they can support the complex needs of their patients and work upstream around the social drivers of health. And of course, a payment reimbursement model that aligns and allows for this is very important. So thank you.
Yeah, great. Thank you for that answer. I like how you have it all pulled together in that strategic thread. Could you say more about whole person care models and their role in addressing equity issues and equitable outcomes?
Yeah, and this is something that we've been talking a lot about with our health centers. And also, I will add that in our state, we have a CCO model, coordinated care organizations, that are basically MCOs for the state of Oregon. And this is also an area of interest of working collaboratively with those Medicaid payers in our state around how we can support whole person care, to really look at, things like housing and other needs that our patients that we're working with at health centers, of how we can best support them on a community level, and really work collaboratively with other partners. I know health centers, often feel like they have so much on their plate, but it's about that relationship development as well, so that they're supporting those needs of of that patient population, and looking at resources such as, for us, the coordinated care organizations that have funding that is available to support work in this space, and is really looking at unique models to best support that care.
Yeah, that's great. We have, I'm sure you're aware, through our Healthy People, Healthy Communities funding area, funded some whole person care models and the development of those models, because we think it's really necessary to focus on the whole person and all of the factors that influence their opportunity to live the healthiest life possible. So thank you for providing that overview. I think that's really helpful. Bob, it looks like you want to say something here.
Thank you, Pam. I would. I think Oregon has and will continue to be a leader in changing the way payers think about the healthcare delivery system, in particular with their APCM model of payment, and providing that steady stream of reimbursement that's not encounter driven. I think I would simply say that the payer community has a significant role to play in supporting the healthcare delivery system to be a more equitable healthcare delivery system. And so states like Oregon, through their primary care association, have really helped couple the public and private payers communities with the community health center delivery system to support those initiatives that promote and expand health equity for the populations that health centers traditionally and continue to serve.
Yeah. Thank you. Anyone else have a comment there before I turn to Yvonne? Alan, did you want to say something?
Yeah, I mean, just on that, particularly, on the COVID side of this, I think that recognition of the social determinants, right? We did receive federal funding to provide support for testing, right? A lot of it was around COVID testing, and in our state, we worked closely with our state to make sure that we were expanding our testing capabilities, not to just our patient population, but to the communities that we were serving, particularly in light of the fact that, we know that racial and ethnic minority populations were getting hit harder. That's our population. That's who trusts us. We wanted to look at doing more than just testing, right? So, hey, we're testing you and you're positive. Now you need to, what we learned as well, as seeking refuge, not quarantine for 2 weeks. It was seek refuge. And how do they seek refuge if their job's at stake, if they don't have the financial means? So you're able to work with the state and really establish a model in which we were addressing those social determinants and the factors that would keep an individual from being able to seek refuge safely and securely, to be able to pay for things such as rent or mortgage or utilities or food. A lot of the patients that we serve as health centers may not have access to publicly available services due to their citizenship status. We don't care. They're in our community. So we wanted to make sure equity was available for individuals who are not citizens as well. And I think it was just, for me, being in Utah, this is not really like it's not something we take for granted in Utah, that ability for our state policymakers to work with us to really recognize the need to address those areas and to make sure that we were providing those wraparound supports and services to keep people safe, right? To lower transmission and to not really put that family or individual in jeopardy of losing everything. So there's something positive right out of these situations. I'm finding more of them these days. And that's really that ability for people to get together and solve problems.
Yeah. I heard, I was really fortunate to hear Dr. Fauci speak about, and he just had 2 sentences about health equity in his remarks, but, he said the incidence of COVID transmission is higher in people of color and people living in poverty because of the type of jobs that they have that don't allow them to work from home or self-isolate. I mean, these are real social issues, right? But then the severity of the COVID, when if they do get it, is more severe because of pre-existing conditions, because of these social determinants of health we're talking about. And I think we just really, all of us, I'm sure you do this every day, but have to step back and think about how all of this is connected to achieving equitable health outcomes. So, okay, now, anyone want to comment on that? I saw some heads nodding, but Rachel?
I don't think anybody can say it better than how you did. You hit the nail on the head, Peggy.
Thank you. Well, I'm loosely quoting Dr. Fauci, but when I heard him say it, I thought that was just brilliant. And it, in 2 sentences, it explained the whole health disparities related to COVID to me. Okay, so now I do want to turn to Yvonne in Idaho and talk about, you know, the healthcare workforce. And you and your team just completed a statewide tour where I understand you delivered to PPE to health centers across Idaho. What did you bring back from that experience with you, and how will that inform how you support the centers moving forward?
Thank you, Peggy, for the question. So when COVID hit Idaho, it hit it in different ways. We have very urban areas and very rural areas, which is pretty common in all the states here. And we were on the phone with our health centers, the CEOs were telling us things, but it was visceral for me. I needed to go see what was happening in their community and what they were living and experiencing. So through the help of the Cambia Foundation, we got a warehouse full of masks and gowns and gloves. And I'm not a great driver, but we had this huge truck. And my communications person who used to drive a fire truck says, I can help drive, let's go. So we masked up and we drove all over the state and we filmed it. And there's a video on the Cambia Foundation website that displays the joy that our health centers experience by seeing us. And by living in their communities, even for the afternoon or the day, we were able to see what they were seeing. There were some communities that COVID hadn't hit. And so you had a very openness. You go into a restaurant, nobody's wearing a mask, waiters, waitresses, and they look at you funny because you are. You go into other areas and they were very shut down. And now those areas that were very open and not wearing masks are the hardest hit right now. So it's coming in waves. And the health centers who were hit first we put together groups, sort of like Jones Affinity Group, to say, okay, well, this is what we did, and this is what the way it worked for us. But each community has such social differences, whether it's cultural, whether it is religious, whether it's just the norm in that community for their acceptance of help and healthcare. And so a lot of our health centers, if they were going to help the people of their community, couldn't react exactly like somebody else reacted. They needed the ability to do something different. Otherwise, people wouldn't trust them. You talk about social determinants and racial disparity. Idaho's known for our potatoes. In some of our potato plants, they refused to test because they didn't want to know, because they didn't want to close down, and they didn't want to report to the health district those outbreaks. But these patients needed care and they needed help, but they almost had to do it under the cloak of night. And that made us better as an organization. There was a certain risk involved, mostly my driving when I had to drive the van, but to go out and figure out what the health centers were living and experiencing, and then be able to bring that back and push out resources beyond the masks and gowns that they sorely needed to protect themselves, to make sure that they could serve their communities and their patients. So it was a great and terrifying experience, but I wouldn't trade it for the world.
It sounds like something that you'll never forget and that you'll incorporate into your work moving forward. That's great. Thanks for
Absolutely.
sharing that with us. Okay, I know we're ending at 2 o'clock here, so we have about 15 minutes left. I want to get in a last question to Bob and then open it up to Q&A from our participants in our audience. Bob, in addition to providing direct services, I know that community health centers serve an important role in policy development and really working with public health departments. How do you see health centers using these roles to address systemic racism that has been revealed during COVID?
Thanks, Peggy, for the question. And again, Peggy and Steve, thanks for all your support and that of the foundation too, to help us move forward in this important way. I want to say good afternoon to all of you who are attending. And I've just written down a few things that I wanted to share with you. Let me begin by stating that I am someone who has lived his entire life in the cultural default of white male privilege. And that's an uncomfortable truth that I'm learning to live with, and a lot of us are learning to understand better. But I'm convinced that we can lead by acknowledging that and by learning to talk about it and remedy it as well. So for me, this is as much a personal journey as it is a professional one. And as Pam and as Peggy and Rachel have noted earlier, the CHC program was born out of the Johnson administration's war on poverty. And it had the aim of delivering affordable, comprehensive care to marginalized populations, and we continue to do that today in every state in the nation. However, many of the societal problems of poor health, income inequality, educational achievement, and housing insecurity persist today. And as health center leaders, we must realize that these disparities continue in no small part because of systemic and structural racism. So if we're intent upon addressing the problems of poor health in the populations we serve, then we must also address the systems of racial privilege and oppression they experience. This is a public policy issue. This is not just a healthcare issue. So in light of this public healthcare crisis, we must become actively and aggressively anti-racist. And to do that, we need to build bridges with our state legislatures, with our congressional delegations, and with community-based organizations and those with lived experience that are outside of our more comfortable healthcare delivery system bubble. I'd like to also say that as health center organizations, we have an opportunity to look inward and to recognize that in many instances, there are significant diversity and inclusion gaps in community health center leadership and at the policymaking level. And if we want to better serve our communities, especially communities and people of color, then we need to up our game, if you will, and fill the equity and inclusion gap at the top. And so as a result of Peggy, your and Steve and the Cambia Foundation's generosity, we've been able to establish a public policy internship position in our organization, and we'll be able to continue that position over time. We are deliberately seeking individuals with lived experience from diverse ethnic and racial backgrounds to help us shape policy going forward. And as a community health center board of directors, our executive committee has made a policy decision that we're going to bring to our board next week, in fact, to make anti-racism a core value in primary care as we deliver it among community health centers in the state of Washington. So Peggy, thank you. And I'll be happy to take questions later. Look forward to the contributions of my colleagues as well.
Well, thank you, Bob. That takes me back full circle to something Rachel said at the beginning about training, right, and inclusion. So very interesting. Well, I applaud you for looking at the systems approach, that how all of these systems fit together, and for digging in on policy solutions that will change the future of healthcare so that we can look to more equitable outcomes. Thank you for that. Does anyone else want to add to what Bob shared? All right. Well, we have 9 minutes left, right, Steve? And so do we have questions coming through? I think I see one, and I can open this up to anyone here. But the question is, do you have any thoughts on the clinical training and supports that would be required for serving people with limited English proficiency? So, how do we help the workforce and train the workforce so that they can serve people with limited English proficiency?
Peggy, if I could start with that, if you don't mind.
Sure.
It's a great question. So thank you to whoever asked that. I think it's also a very powerful question, and it's a loaded answer. And there's a lot of there's not one small answer that's going to do everything. But I think the biggest effect to the workforce would be if they were able to be trained, that more of their training would be done actually hands-on out in the field and not within the four walls of the institution where the training programs happen. Because they need to be able to actually experience healthcare delivery in the real world. Sometimes, all the times in the training programs, they have the best equipment. They have best access to the specialty cares and anything else that they will need. That's not necessarily the case out in the real world. So they need to be able to understand how they have to maneuver through all of those challenges, and then couple that on top of the fact that they're going to be dealing a lot of times with individuals that don't have resources, or they have very limited resources. And as the question implies, that they may have limited English proficiency. It's important that we all understand that it's not just the issue of the barrier of English, whether they speak English or not. It always comes with that, the understanding that the culture is going to be different. Couple that with the fact that, if you're from one race, it doesn't mean that everybody's the same within that race. And I'll take the biggest example to me the easiest example is Hispanics. Not all Hispanics are the same. There's so many different cultures, and even the way we use our words are different within the different languages. Even though a lot of it may be Spanish, our words have different meanings depending on where you're from. And so understanding all of that is not something that can be taught within the four walls of an institution, of a training program. It needs to be out in the field. They need to be actually experiencing and learning from their patients and learning from the people of that community that already know, because these are their neighbors. Those patients are their family members, or their neighbors. They know them already. And so learning from their colleagues on the medical team, on the care team, is probably the best experience that they could have. And so I felt like I was so negative. Let me give you a positive. The easiest thing is for the clinicians to truly understand it, all of the healthcare team at all levels, that the patients are just looking for the individual's heart, for their corazón. What is their heart? And it doesn't matter what color they are. It doesn't matter what language they speak. If that care team member can let their heart be felt by that patient, that's 50% of the battle. That's 50% of the challenge, because that's how they earn their trust, right? And then, as you mentioned, Peggy, so well earlier, it is about earning that trust and then maintaining that trust. So if you can get that trust, then the rest, and you're willing to learn and you're willing to have an open mind, then the rest comes.
Yeah, thank you. I love that. Speaking from the heart maybe can overcome some of the language barriers. That's well said. Yvonne, I saw that your hand went up. Did you want to add to that answer?
Yeah, I would agree with Rachel that it is more about culture than so much about language. I mean, there's many translation services that you can speak in that person's language but that doesn't mean you're going to communicate with them. We have some of our health centers that we have a lot of Hispanic camps, farm camps in Idaho, and they go out to the camp to do the services because they can't get the people to come in for a number of reasons. Fear is one, transportation issues is another, and culture is another. So they have to absorb into their culture to be able to communicate with them better. Likewise, we have a number of refugees that come to Idaho, as do all states. And so our health centers specifically who treat refugees seek out providers who come from that culture because they know the norms. They know how to, when it has to be a female with a female, they know those cultures. We even had one of our health centers share with me that they had a patient's baby die in the hospital. And so the whole refugee community refused to have their babies in the hospital because they thought in their community, they didn't have they had their babies at home. They didn't have them in a hospital. And so they really had to overcome that cultural barrier that it is safe to seek, Americanized care. So I wanted to add a little bit more about the cultural aspect, and you really have to get out in the community and make sure that you're addressing people at their needs at their level.
Thank you. Thank you. One, and I agree with you, that culture is so important and hard to learn unless you're actually in it and that lived experience, as Rachel mentioned. I think this may be our final question since time is short, and I'm going to ask Joan to answer it first, but then open it up to anyone. What do you see as our biggest opportunities to advance health equity in 2021?
Wow. In 2021, given COVID, I definitely think this year is going to continue to look a little different. I do think that we're already doing a lot, and it's going to be hard to ask for anything more. So I would say, use the information that we have, the data that we're collecting and reporting. The health centers are reporting to HRSA around, what that looks like for, COVID testing. Our health centers that are capturing, like I said, race and ethnicity data around that population that they're testing. They need that information to help them with their decision making, but it's going to be too much to ask them to really take on new things. I would say, they are already seeing these disparities, they're aware of them. So, without asking them to really do more, using that information to really inform decisions and to track that and to really look at, are they making a difference within those communities? I know one of our large providers that's been going out to to serve farm workers, and their rates of positivity are so high among that population that they're serving. And so they're using that information to do more outreach, and they're using that information to look at how they can work more upstream and how they can also then work with employers as well around having some needs to help mitigate that the infection rate among those, the farm worker community that they're working with. So it's going to be hard in 2021 just with everything they have on their plate. And I'd say, it's going deeper into what they're already doing and really ensuring that they're doing that well.
Thank you. Well, and if I summarize one thing, a nugget I think you said was use data to inform decisions and prioritize resources. So I think that's good advice. No, but that was really good advice for all of us. Does anyone else have a thought on the opportunities for us ahead of us in 2021 to address health equity?
I think I would just echo what Bob said earlier, which is, not sort of resting on the fact that, boy, we're health centers and we already have addressed this. It's really continuing to take a look inside at our own perceived biases and areas that might be preventing us from doing more and addressing equitable care. I think we have room to grow as well, and it all starts with taking a look at ourselves and then expanding on that.
Thank you. That's a great place for us to end this webinar. I've learned something from each of you today. I thank you so much for joining us. Thank you for being part of this work and working in partnership with the foundation to address disparities. Steve, thank you for everything you've done to pull this webinar together. We appreciate you, and especially appreciate that you got all dressed up for us today. And no, really, thank you for everything you've done and for driving this work. We appreciate you. All of our grantees and guests, thank you so much for joining us today. You make our work more fun and more impactful. So thank you. And take care, everyone. Bye-bye.
You.
Thank you, everyone.
Thank you.